Okay, so this is neonatal jaundice. So, as earlier described, we talk about the most important aspects of neonatal jaundice, starting with a definition of jaundice, causes of neonatal jaundice, normal physiology of jaundice, or let me say normal physiological bilirubin conjugation. Then we talk about the pathophysiology for jaundice, management of jaundice, and the other things that you're going to do. Then you also add in the assessment or diagnosis, history, clinical features, laboratory investigations, the treatment, the nursing care, and lastly we'll do the complication of jaundice. So this is the outline that we're going to follow. So starting with the definition, so you can go with any of the two outline definitions. So with the first one, we are saying jaundice is the yellow discoloration of the skin and the sclera which result from the raised levels of bilirubin in the blood. So neonatal jaundice occurs in a condition whereby you find that there is raised levels of bilirubin that causes the yellowish discoloration of the sclera and the mucous membrane. Henceforth, you need to understand where jaundice is. It is because of the bilirubin that is raised in the blood circulation. So if you want, you can go with the second definition, which says it is the yellowish discoloration of the skin, the mucous membranes, and the sclera in a newborn due to accumulation of unconjugated bilirubin in the circulation. One thing that you need to understand is that bilirubin is of two types. There is conjugated bilirubin and unconjugated bilirubin. Unconjugated bilirubin is the one that is fatty soluble and cannot be excreted either in urine or in feces. Hence, if there is raised levels of unconjugated bilirubin in the circulation, someone may have neonatal jaundice. If at all there is raised bilirubin levels, of which we are talking about unconjugated, there will be jaundice. The other type of bilirubin that I can talk about is the conjugated bilirubin. So conjugated bilirubin doesn't cause jaundice because this one, it is water soluble and is easily excreted in urine and feces. So from the two definitions that have been outlined, you can choose any of the two as your best definition and get the 5 marks that you want. Then we look at the types of jaundice. So look at the types of jaundice. So the types of jaundice are two, of which we have the physiological jaundice and the pathological jaundice. So now, what differentiates the physiological jaundice from the pathological jaundice? So the physiological jaundice, just from the word itself, physiological, it occurs a normal transition. It occurs as a normal transition of bilirubin or raise in bilirubin levels in the blood circulation. That's physiological. So if you talk about pathological, we are talking about there is an underlying cause. So now, if we try to look at one of them, if you say physiological jaundice, you are going to say this one, it will occur or may manifest in the neonates after 24 hours. In 50% of them, infants, usually 2 to 3 days. So you are going to find that physiological jaundice only occurs after 24 hours of birth, and mostly it occurs 50% of term infants usually 2 to 3 days. So you find that those babies who are born at term, they may have physiological jaundice. Only 50% of those may have physiological jaundice. But take note, those that are born prematurely are more susceptible and may have 80% of this kind of jaundice, which is physiological jaundice. So under the characteristics, you may be asked to write the characteristics of the types of jaundice. So these are the things that we are supposed to be writing. We talk about occurs after 24 hours of birth and occurs 50% of term infants. Then the other thing that you can also talk about, it usually disappears by 7 in term babies. So by day 7, you find that physiological jaundice may disappear in a term baby, and by day 9 or 10 in a preterm baby. So those who are born prematurely, for it to disappear, it may take some time. So in this case, the baby appears to be well. So the bilirubin levels never exceeds 200 or 215 millimoles, or we can say 12 to 13 milligrams per deciliter. So you need to understand, if you are asked to talk about the characteristics of physiological jaundice, talk about the onset of which we said occurs after 24 hours of birth, and it occurs about 50% of term infants and 80% of preterm infants. Then also talk about the time that it disappears, of which we say 7 days in a term baby and 9 to 10 days in a preterm baby. Also talk about the levels of bilirubin, of which we are saying the levels of bilirubin never exceeds 12 to 13 milligrams per deciliter. Then you've outlined, or you've described, physiological jaundice. So now we talk about pathological jaundice, of which we said that there is an underlying cause to this type of jaundice. There is something that is leading to the child or baby to have this jaundice. So now let's try to look at this. So pathological jaundice, this is a type of jaundice that appears earlier. So this one will appear within 24 hours of birth, not after, but within, and is persistent or associated with high bilirubin levels. So for this one, pathological jaundice occurs within 24 hours, and you find that there will be persistence in terms of its occurrence, and it will be associated with high bilirubin levels. So now, the serum bilirubin levels are greater than 12 milligrams per deciliter. If you try to associate it or try to compare it with the physiological jaundice, we said the serum bilirubin in physiological jaundice does not exceed 12 or 13 milligrams per deciliter, but in pathological jaundice, you are going to find that 12 milligrams will be exceeded. 12 milligrams per deciliter will be exceeded in a term, and greater than 15 milligrams per deciliter in a premature baby. So note that the preterm babies have got higher rates of bilirubin levels in their body system or in their blood system. Why is it that? So it's because we have to understand the conjugation of bilirubin, of which it is undertaken in the liver. And if a child is born prematurely, it will be born with the premature lungs, and hence making the child to be more susceptible to have higher levels of bilirubin, because the enzymes responsible for conjugation of bilirubin are not there, hence putting them at more risk. So now, away from that, we are also going to say it may increase more than 5 milligrams per deciliter in 24 hours. And this is what will help to suggest that this is pathological jaundice. So what helps us to know that this is pathological jaundice? It occurs within the 24 hours, and also the rise in the serum bilirubin levels. So we need to understand, like I said, the pathological jaundice have got an underlying cause. So it has a number of causes, which includes increased hemolysis or hemolysis. So hemolysis means breakdown. So if there is an increase in the breakdown of red blood cells, it will cause an infant to have jaundice, because the byproduct of red blood cell destruction is bilirubin. The end product of red blood cell destruction is bilirubin. So that's why we said it may have an underlying cause, and this cause may be increased hemolysis. So now let's try to look at the conditions in which there will be increased hemolysis. So you'll find that a child who may have, let's talk about sickle cell disease. So in a sickle cell disease patient, you find that the destruction of the red blood cells is very high, hence making the child or someone to have pathological jaundice because of high red blood cell destruction. The other things may be metabolic and endocrine disorders and also infections. Infections may also lead to pathological jaundice. So these are the characteristics of which we're supposed to talk about. So now, away from the types of jaundice, we talk about the causes of jaundice. So the causes of jaundice are going to be outlined in 3 stages, and of which we are supposed to know them in this way, which will be easy for you to understand. So let's look at this. Neonatal jaundice is as a result of the discrepancy between the red blood cell breakdown and the baby's ability to transport, conjugate, and excrete the unconjugated bilirubin. So the causes of neonatal jaundice we are talking about, it all deals with the discrepancy that is between the blood cell breakdown, the rate at which the red blood cells are being broken down, and the rate at which the bilirubin is transported, conjugated, and also excreted. So if there is a delayment in the transport, conjugation, and excretion of this, it will lead to what? Jaundice. So these 3 things: transportation, conjugation, and excretion. So if you talk about transport, let's talk about other conditions. There are conditions whereby there will be impairment in the transportation or flow of the bilirubin. So you find that someone may have jaundice. Conditions where the conjugation is impaired because of lack of the gluconue enzyme that helps in the conjugation of bilirubin. You will find that it may lead to what? Jaundice. Excretion of unconjugated bilirubin. If this unconjugated bilirubin is not excreted, and of which we know it cannot be excreted because it is fat soluble, hence it will cause, or it will start causing, the yellowish discoloration of the mucosa, the sclera, and all that. So these are the causes of jaundice. So now we try to talk about them in a way that is well arranged in a synchronized manner. So let's talk about the excessive hemolysis or excessive hemolysis. So if you talk about hemolysis breakdown, so if there is an increase in the breakdown of red blood cells, you'll find that there will also going to be an increase in the levels of bilirubin, because we do understand to say red blood cell destruction produces the end product known as the bilirubin, hence causing an increase in the blood circulation. So excess hemolysis, so it occurs more than twice that of a normal adult per kilogram of weight. So in the hypoxic environments of the uterus, the fetus relies on the fetal hemoglobin, which has a higher affinity for oxygen than does the adult hemoglobin. So you need to understand, even the conjugation of bilirubin is also accompanied or is also facilitated by the presence of what? Oxygen. So to be quick on this point, excessive hemolysis, where there will be excessive red blood cell destruction or breakdown, it will lead to excessive production of bilirubin, hence causing an increase. So that is about that. So now, this excessive hemolysis, how Okay, how does it come about? What may cause excessive hemolysis? So what causes excessive hemolysis or excessive red blood cell breakdown? Number one is A or B and the rhesus incompatibility, where you find that the A or B system, or let's say the blood group of a child and the mother, are incompatible. Hence, you are going to find there is going to be more like a reaction that will start causing these red blood cells to be broken down, hence leading to jaundice. You talk about hemoglobopathies. So hemoglobopathies, like I said at first, we talked about sickle cell disease and the thalassemia. So sickle cell disease, I said, in sickle cell, the normal destruction of red blood cell is of 120 days, but in sickle cell disease, you are going to find that there is a reduction in the destruction of the red blood cell, of which it reduces to 20 days. So now, if that happens, it causes an increase in the number of bilirubin in the circulation. Talk about enzyme deficiencies, like if the child has deficiencies in the enzymes that conjugates bilirubin, such as glucose 6-phosphate dehydrogenase, which is G6PD, is an enzyme that is responsible for conjugating bilirubin. So if a child lacks this enzyme, it becomes impossible for bilirubin to be conjugated, hence leading to an increase in the levels of bilirubin. So now, away from the enzyme deficiencies of which we've talked about, if the G6PD is not available in cases whereby the child is born prematurely, you find that the enzyme will be absent, and hence it will not be there to conjugate that bilirubin, hence causing a rise. You also talk about familial spherocytosis. Familial spherocytosis, where we are talking about, this results in fragile membrane of the red blood cell, resulting in hemolysis. So the structure of the red blood cell is not as normal as the way it's supposed to be, and it is fragile. Hence, it is going to be distracted, or it's going to be broken down by the spleen, hence leading to bilirubin production. The other thing is sepsis, infections. So infections may also lead to increase in bilirubin levels, because red blood cell destruction will be there. For example, we've got conditions like diseases like malaria, so that can happen. Polycythemia, which we are saying a lot of red blood cells, a lot of red blood cells, or an increase in the number of red blood cells. So this causes the destruction of red blood cells, and hence causing a rise in bilirubin levels. So these are the causes of jaundice, or we said excessive hemolysis. How is that excessive hemolysis coming in? It is coming in as a result of hemoglobopathies. It is coming in as a result of enzyme deficiencies. It is coming in as a result of what? A or B incompatibility, and also sepsis and polycythemia. So all these factors may lead to excessive hemolysis. So away from that, we talk about also breast milk jaundice. Breast milk jaundice. So breastfeed infants are more likely to be jaundice than those who are artificially fed. This should be investigated in order to ensure that there is no other underlying causes. So you're also going to find that breast milk jaundice, you're also going to, some of the components that are found in the breast milk may predispose the child to have jaundice as well, or may predispose the child to have excessive levels of bilirubin in the circulation. Talk about the other factor, which is galactosemia. So galactosemia, we are talking about the area of metabolism where there is deficiency enzyme required in the conversion of galactose into glucose, will lead to persistent jaundice. Also, these factors are also contributing to jaundice, a lot of them. The other thing is defective transport, defective transport. So if there is an impairment in the transport of this bilirubin, it also going to cause someone or an infant to have jaundice. So we are saying this will be as a result of factors that lower the blood albumin levels or decreased albumin binding capacity, as in hypothermia. So if a child is hypothermic, okay, sorry for that. So we talked about the defective transport. So this will be as a result of factors that lower the blood albumin levels or decrease albumin binding capacity, as in hypothermia. So you need to understand to say bilirubin is binded to albumin. It is binded to albumin. So in case of any condition that impairs that binding of albumin to bilirubin so that it can be conjugated, is what will lead to higher levels of bilirubin in the circulation. So we talk about hypothermia. So hypothermia, acidosis, or hypoxemia, which means low levels of oxygen. Like I said, for conjugation to take place, there is need of the presence of oxygen. So if there is hypothermia, there is acidosis, or there is hypoxemia, they can interfere with the albumin binding capacity. Other drugs that may compete with bilirubin for albumin binding sites like aspirin and also sulfonamides and the ampicillin. So these drugs may also contribute to someone having jaundice. So now we talk about the conjugation. How it may cause jaundice. So in addition to the immaturity of the neonate's enzyme system, other factors which can interfere with the bilirubin conjugation in the liver includes the following. So factors that may interfere with the conjugation. Factors interfering conjugation are the following. So dehydration will interfere with conjugation. Starvation, low levels of oxygen like earlier explained, infection, sepsis, oxygen and glucose are required for conjugation to take place. So if there is absence of these components, conjugation cannot take place, and hence someone will have high circulating and conjugated bilirubin, leading to jaundice. We also have some infection such as toxoplasmosis, rubella, cytomegalovirus, and herpes. Neonatal viral hepatitis, these may also lead to an impairment in the conjugation of bilirubin and hence leads to jaundice. Bacterial infections such as E. coli, metabolic acidosis, all these may lead to jaundice. So it is very important to understand the causes, because we know the causes are broad, because where we started with excessive hemolysis. From excessive hemolysis, we had to outline the causes or things that may increase red blood cells production. We talk about conjugation, factors that affects the conjugation, and those factors are the following that we've talked about. Hence, these can cause jaundice. The other causes of jaundice includes excretion. So factors that can interfere with bilirubin excretion includes, so those factors that are going to interfere the excretion of bilirubin, we are talking about hepatic obstruction caused by congenital anomalies such as extrahepatic biliary atresia. So in a condition where you are going to find that there is impaired or there is obstruction in the extraction in the flow of the bilirubin and bile, you are going to find that the person may have jaundice, like biliary atresia, whereby there will be more like a closure in the biliary tree, hence obstructing the flow of bile. So obstruction from bile plaques, from increased bile viscosity. So if at all An individual also has an increase in the thickness of bowel. It leads to reduced motility of the bowel, hence leading to jaundice. The example given that is there is cystic fibrosis or a total or parental nutrition. Hemolytic disorders and dehydration are also part of excretion or factors that may reduce excretion. Saturation of proteins carriers needed to excrete the conjugated bilirubin into the biliary system. Also, if there is impairment or there is inadequate carriers of conjugated bilirubin, that needs to be removed out of the biliary system. So that will lead to jaundice as well. Infections also, other congenital disorders and idiopathic neonatal hepatitis and others may also cause the process of conjugation to be impaired and hence leading to jaundice. So now, away from the causes of jaundice, we talk about the normal physiology of jaundice. I know where we've come from, maybe the information maybe at one point be jumbled and all that, but the physiology of jaundice, or let's say the normal physiology of bilirubin conjugation, is the most important aspect for you to understand the pathophysiology for jaundice. So now, there are some key components that you need to understand in the normal physiology of how bilirubin is conjugated from unconjugated to conjugated for it to be removed from in feces and in urine. You need to understand as red blood cells break down, they break down into what is known as what? Hem, or hemoglobin is broken down into three components. There is hem, there is iron, and there is globin. So all these three components are very important for us to understand. So let's now go through this. So now, to understand the pathophysiology of jaundice, there is need to first look at the normal physiology of bilirubin conjugation. And this is the bilirubin conjugation that you're talking about. So conjugation of bilirubin. So bilirubin is a waste product from the broken down of red blood cells, or RBC, sorry. So if the red blood cells have been distracted, have been broken down, the byproduct is the bilirubin. So that's why I said it is a waste product of red blood cell breakdown. So we are saying aging, immature or malformed RBS are removed from the circulation and then broken down into the reticuloendothelial system. So you need to understand, very simple, you need to understand the immature red blood cells, the aging red blood cells, and the malformed red blood cells, such as the SICOD, the one present in sickle cell disease. They are going to be removed from the circulation or broken down in the reticuloendothelial system that is present in the liver, the spleen, and the macrophages. So these three components are the ones that contains the reticuloendothelial system that breaks down the red blood cells. Then that leads to the following. So hemoglobin is broken down into byproducts of iron, heme, and the globin. Three components: iron, heme, and globin. So we now talk about the heme itself, the iron itself, and the globin. What are these things? So heme is turned into biliverdine. The heme is turned into biliverdine and then to unconjugated bilirubin with the help of the enzyme biliverdine reductase. So you need to understand the breakdown of hemoglobin. There is three components that are released. There is iron, there is heme, and globin. So for heme, it is turned into biliverdine that is later converted to unconjugated bilirubin with the help of the biliverdine reductase. So we have the globin, which is broken down into the amino acids, which are then used by the body to make proteins. Iron is stored in the blood, in the body, or used to form new RBCs. So these three components that makes up hemoglobin have their specific roles. So understand, for now, I just want you to get the heme the heme, which is the broken down of hemoglobin. We're just going to get heme. So hemoglobin is turned into biliverdine, then into unconjugated bilirubin. So now understand this, keep this in mind. For now, we've got unconjugated bilirubin. Let's keep going. So the two main forms of bilirubin found in the body are, so we've got two main forms of bilirubin. So we've got conjugated bilirubin and unconjugated bilirubin. So unconjugated bilirubin is fatty soluble, like I've been said. So it is fat soluble and cannot be excreted easily in bowel or urine or feces. It cannot. Then the other form is conjugated bilirubin, which has been made water soluble. So this one that has been conjugated, it is now easy for it to be removed out of the circulation, either in feces or in urine. So these are the two forms of bilirubin. But keep in mind, in your mind, to say heme has been converted to biliverdine, then later has been converted again to unconjugated bilirubin with the help of reductase enzyme. So now, there are three stages that are involved in the process of bilirubin conjugation, and these are, note that these factors in other notes may not be present, but it is very important for your own knowledge to note the normal physiology of bilirubin conjugation. So the three factors are important in the normal conjugation of bilirubin, and these are the transport of bilirubin, the conjugation of bilirubin, and also the excretion of bilirubin. So now let's try to look at the transport of bilirubin. So the transport, so unconjugated bilirubin is transported into the plasma to the liver to bond with the plasma protein albumin. So in the liver, when we said there is broken down of hemoglobin, that heme which is converted to unconjugated bilirubin, it is transported to the liver. Where it goes to the liver, it combines or it binds with the plasma protein, which is albumin. So it is going to bind together with albumin. If you remember to say, we talked about on the causes, we said there are some factors that increases the ability of albumin to bind with the unconjugated bilirubin. So now we're saying that unconjugated bilirubin in the liver now will be combined with the albumin. So if not attached to albumin, it can be deposited into the extravascular fatty and nerve tissues in the body, causes straining of the skin, jaundice, and the brain. So if it has not binded, if it has not attached in the liver, it may go into the extravascular fatty and the nerve tissues, where it's going to cause some impairment. You can go to the brain, where it may cause connectors. So you need to understand bilirubin staining of skin and toxicity to the brain result into a condition known as the connectors, like I have said. So for now, keep in mind to say we are still in the liver, talking about the transportation from where it was broken down to the liver now, where there is a combination. So now we talk about the conjugation of bilirubin. So now there has to be a conjugation from unconjugated to conjugated, from fat soluble to water soluble, from a form of which cannot be excreted to a form of which it can be excreted. So let's look at this. Once in the liver, bilirubin is detached from the albumin and transported by the intracellular carriers protein Y and Z, which is the ligand, so to the smooth endoplasmic reticulum of the liver. Bilirubin is combined with the glucose and the gluconic acid. So in the presence of oxygen facilitated by the enzyme known as uridine diphosphate glucuronide transferase, which is the UDP-GT or the gluconide transferase. So here where we've reached, this is where there will be conjugation. Since this has been transported to the liver, the conjugation, there is binding of the albumin and unconjugated bilirubin. They bind it in the liver. Now you are going to find that at this point we are going to find that they are going to be an acid of which they've mentioned to say the gluconic acid. The gluconic acid and oxygen are going to be there, and also in the presence of the enzyme known as a UDP and GT, or gluconeotransferase enzyme, are the one that are going to cause now the unconjugated bilirubin to be conjugated from fatty soluble to water soluble. So what is causing this conjugation process is just being helped by gluconic acid, uridine, oxygen, and the UDP-GT, or gluconeotransferase enzyme, hence causing the conjugation to occur. So hence, just know conjugation of bilirubin is facilitated by this enzyme, uridine diphosphogluconeotransferase. So these terms sometimes just how you pronounce them yourself. So the conjugated bilirubin is now water soluble and available for excretion. So at this point in time, the conjugated bilirubin can now be excreted out because it has now become water soluble. So now we talk about excretion of the bilirubin. So in the conjugated bilirubin is excreted via the biliary tract into the small intestine. So it is going to pass through the small intestine, or the biliary tree, then goes into the small intestine where the duodenum is connected, and then it is excreted in urine. So we are saying it is catabolized normal intestine bacteria to form urobilinogen and stectobilinogen, then oxidize into orange colored urobin and stectobilin. Most of the conjugated bilirubin is excreted in feces and the stectobilin as parts, but a small amount is excreted in urine as the urobilin. So from the excretion, since it has now been conjugated, so it now has to be excreted in feces, and some has to be excreted in urine. So get this point again. From the biliary tract into the small intestine, where it is catabolized, there is broken down by the normal intestine bacteria flora. So there is a normal flora in the intestine that causes that catabolism to take place, where there will be formation of urobilinogen and the stectobilinogen. So that conjugated bilirubin will be broken down into urobilinogen and the stectobilinogen, then going to be oxidized into orange colored urobilin and the stectobilin. So that is what happens in the excretion, then removed some in feces and some in urine. So now that is the normal. So now, if at all there is jaundice, or jaundice occurs, how does it occur? So in the newborn babies, there is also increased the intrahepatic reabsorption, as the neonate lacks normal enteric bacteria that break down the bilirubin into urobilinogen. So if you said in the normal flora, there are supposed to be a bacteria that causes that catabolism to take place, so that that conjugated bilirubin will be broken down into what? Into stectobactin, and also converted to urobilinogen. So in an infant, you are going to find that it is not present. Hence, you are going to find that it will be impossible for that process to take place. So now, there is also an increase in beta-glucuronidase enzyme activity. This enzyme hydrolyzes conjugated bilirubin back into an unconjugated state that also raises the serum bilirubin levels, delayed feeding of the neonates, further compromise the excretion of unconjugated bilirubin. So again, you're going to find that there is this enzyme that is increased, or that is in an increased number or in abundance, so which is according as beta glucuronidase enzyme. So this one, it reconverts back the conjugated bilirubin to unconjugated bilirubin, that now causes the skin to become discolored by that color we are saying yellowish discoloration of the skin. So all in all, where the pathophysiology is coming in, it is whereby if at all we have immature lungs, where we are going to have that the gluconeotransferase enzyme responsible for conjugation of bilirubin is not present. Also an increase in the enzyme known as beta glucuronidase enzyme that converts back the conjugated bilirubin to unconjugated. These factors leads to bilirubin, and also in the presence of the causes that we talked about, and in that way you've talked about the bilirubin conjugation or the pathophysiology. So the management of jaundice goes in with the principles of management, of which have been underlined, of which we talk about timing is very crucial in the management of jaundice, and assessment and diagnosis. You need to make sure that you follow all these factors. Obtaining of history, talk about the history. So obtain the history from the mother on the onset of the condition, whether it is from the physiological breakdown of bilirubin or the presence of another underlying factor. So all those things may be noticed only that. So the clinical features from the pathophysiology and from the definition, we can get them. So we have the same yellowish discoloration of the skin, we've got the lethargic, we've got fever, irritability, passing of pale stool, and also urine have a deep yellow thing. We also have kernicterus, where if the bilirubin goes into the brain. So this you'll find that it begins with a poor feeding, there will be vomiting, drowsiness. The baby will also have spasmodic backward aching or upwards rolling of the eyes, and also seizures will occur. So this is the many, or what I can say about about jaundice. Then the other thing just remains as the management. So the main management for a child with jaundice is phototherapy. That's what you're supposed to know. Then you add in these other things: infection prevention, also provision of nutrition, also provision of home thing in an incubator, and all that. The psychological care to the mother, also the blood transfusion or blood exchange. So these are the main things that we can talk about in management, just as wise. So if there are any questions, anything not clear, you can ask.